So it is my pleasure and gratitude that I introduce our next panelists for our panel that is looking at income insecurity today. I welcome Angela Robertson, Executive Director of Parkdale Queen West Community Health Center, followed by Tracy Smith-Carrier, Associate Professor, School of Social Work, King's University College at Western University. Thank you again to you both, and I turn it over to you, Angela.
Hello there. So thank you for the opportunity to be part of this conversation. And in speaking about income insecurity, the lens that I want to take to this conversation is bringing an equity and an intersectional lens to how we have the conversation and how we think about income insecurity, and in the context of patients and redefining the future of healthcare is how do we think about income insecurity with an intersectional lens. So I think it is important to acknowledge, and the thing that I think we know, but important I think in this context to just keep repeating that we know that our health is deeply intertwined with our economic status, and both health and economic status are heavily influenced by social factors that are beyond the individual control. So when we talk about income insecurity and health, is that we're talking about system, and therefore the need for systemic changes to ameliorate and address these sites of disparities. And that as well, we need to think about the broader social determinants of health. So when we think about income insecurity, we also need to think about the interconnections with issues of race, issues of ethnicity, issues of indigenous identity, issues of gender identity, immigration status, and the rural-urban divide. So we cannot afford to think of solutions in a single strand because of the interconnected nature. I want to kind of frame a little bit when we think about income insecurity, the present moment that we're in. So we are in this present moment of COVID-19, a pandemic. And what we have seen with COVID-19 is the impact. We have seen the impact and the differential impact of COVID-19 on a range of communities and populations. So in this city, in Toronto, where I am, we have seen that 79% of reported COVID-19 cases where racialized ethno-racial data was collected, we have seen that where ethno-racial data was connected, that 79% of the individuals who have been impacted come from racialized populations. And that really, this represents a 3.4 times the ratio of white populations here in the city in terms of COVID-19. And that of that, 72% of those who have been hospitalized have been racialized. And additionally, that we have seen the acuity in positivity rates among populations where low-income people live and reside, and where low-income people live and reside is also correlated with the presence of a high ratio of racialized individuals. I start there because I want to draw our attention to the fact that conditions that existed pre-COVID, so the disparities around income, the disparities around gaps in social determinants of health that existed pre-COVID was the stage setting for the differential impact that a pandemic like COVID will have and is having on populations and communities. So when we think about income disparity, no, we also need to think about how continuing to continuing to have these rates of disparities can become real fertile ground for exacerbating detrimental impact and consequences for populations moving forward when an issue like COVID-19 presents itself. And I think as well that we then overlay, we're in the moment of thinking about the coming of vaccine. And therefore, when we take an equity and an equity lens to the ethical conversation about who gets vaccines first, is we also need to bring an equity lens that also look at who are the populations that are differentially impacted. So just feeling that as we have this conversation in this moment, that we need to think about that. I won't go on at length about where the sites of inequalities exist in terms of income disparity, but I would signal that women still earn 78 cents on average for every male dollar earned. So we know that there continues to be a persistent disparity in that is gender-based in terms of income. And that when we look within the category of women, is that we see still a differentiated in terms of disparity, where you have racialized women, indigenous women earning less than their white counterparts. So even within the gender categories where we see income disparity, is that their differentiated impact. One of the things that we know is that folks who are poor have poorer health outcomes. And they have poorer health outcomes because they have less access to good jobs, and good jobs we know come with things like benefits, and we know things like benefits comes with enabling access to good and quality health care. The other thing that we know is that folks who are poorer have a lower life expectancy. So we know that women who are poorer die earlier than women who are richer. Likewise for men as well. So we know that there is not just a theoretical in terms of perspective around these differentiated impacts, but there's a practical, tangible and detrimental impact for these sites of disparities. Some of the things that I think we also know is that folks who are poorer, when we look at cancer screening rates, is that they have lower cancer screening rates than their rich counterparts. And what that means is that if you have a lower screening rate because you're in the low income quintile, is therefore when you finally get screened and a cancer is detected, is the likelihood is that your detection is at a later stage, which then leads to a higher mortality rate for low-income communities. The other piece that I think it's also important to note, and I know that in the previous panel, there was, the focus on mental health, is that half of in terms of poorer individuals report poorer mental health, but also folks who are low income show up in emergency as their first point of contact to access mental health services and support. And we know that folks who are racialized, particularly folks who are Black, show up for mental health support through the justice system. So usually because there's a police intervention. So we know then the differential implications for low-income folks around mental health services and mental health impact, but then also racialized folks and where that entry for racialized folks and specifically Black folks in terms of accessing service. So when I think about and when I suggest to you that as we think about income insecurity, we need to think about we need to think about differential impact, and we need to think about intersectionality, and intersectionality being the various convergences of our identities that can produce different sites different experience of inequality, but also magnify that inequality differently based on race, gender, sexual orientation, disability. We heard earlier in the earlier presentations around the differentiated impact for people with disabilities. And we know that people with disabilities have a higher a higher distance in terms of workforce participation because of discrimination, in terms of hiring folks with disability, and therefore higher rates of poverty. So when we think about intersectionality, we need to, as I said earlier, we need to look at all of the sites of inequalities that folks experience, and therefore map strategies that seeks to ameliorate those sites of inequalities and bring an intersectional lens to those sites of inequalities. And when we bring that intersectional lens in the context that we're in this moment, it's important for us to talk about the impact of race and racism. So the impact of being racialized and the impact of racism and the impact of anti-Black racism and anti-Indigenous racism. Because we're in a moment particularly where we have seen that magnified by COVID, and we are in this, land of Canada, whereby we are very much subscribing to the notion of multiculturalism, and the notion of multiculturalism has really muted, I think, our ability to name racism, to name race and to name racism as determining factors for health. And I think this moment allows us to make that call. And we just saw what happened with our sister, Joyce Echequan, the Indigenous sister, in the Ottawa Hospital, and what happened there as a current example. So this is not historic issues. These are present day realities that we must contend with. So when I think about what are some of the changes that and sites of changes that I think we need to lift up to address the inequalities that are magnified by income disparity, is I think about two strands. I think about the policy changes, and I think about the basic needs, tangible changes. So my position would be that social policy is health policy. And therefore, the social policy and policies that I would recommend that we think about in our various networks advocating for is an increase to minimum wage. We saw in Ontario that was on the books and new government change, and that was receded. That we need to have a good job strategy, and that these two pieces need to be twinned with the strategies that governments are lifting up as part of their pandemic recovery plan. Because pandemic recovery plan cannot be a return to pre-pandemic conditions for many of the populations that we are talking about, that when we say low income. And therefore, this moment, I think, also calls for some policy changes with regards to protection for essential workers. So when we think about income disparities and who are the essential workers, is the essential workers are largely low wage earners. They are workers who are in precarious employment without benefits. And this is a moment that calls for some advocacy to correct that. Another social policy that I would say it's important for us to think about advancing is social assistance rates that are indexed to cost of living. So right now, if you're in Ontario, your social assistance rate is about $580 plus for a single individual. And we know that housing for a single individual is over $1,200 a month. And that's called affordable. And therefore, this flips me to, in this moment of that we need to think about one of the solutions around ameliorating and addressing sites of inequality around income disparity is a focus on rent geared to income strategies and affordable housing strategies. I'm sure others have talked about national farmer care, and in terms of the Brenda earlier in the first, I think, panel in this series, as an Indigenous sister, I think we need to think about and push for the full implementation of the Truth and Reconciliation recommendations, as well as the Missing, Murdered, and Indigenous Women's report recommendations. Currently, we're in the middle of a national childcare plan. We have seen with COVID that women have been dislocated from the workforce, but we know that it is not all women who have been dislocated from the workforce, that essential workers who are largely racialized are still very much participating in the workforce, but without the childcare supports needed. So a national childcare strategy is one. And then lastly, I would suggest that as somebody within the healthcare setting is we need to think about how do we integrate what is now called social prescribing, social medicine, social care in how we deliver healthcare services that really integrates a broader determinants of health lens that can look to what are the differential supports that low-income patients will need as part of the prescription needed for them for better health. And I will lastly just comment on, as I know we're going to be heading into breakout rooms and talking about what are some of the tangible ways in which patient and patient networks can begin to plan and convene, is I think patient networks also need to think about different strategies around how to engage low-income patients. So we need to take a population lens and a population engagement lens to how we engage different populations, because just having a patient advisory does not mean that Angela, who is an essential worker working various odd hours, can have room to participate in those kinds of structures. And therefore we need to lift up different kinds of strategies to engage low-income communities who are pressed up against not having time for meaningful participation and co-creation in some of the strategies that we have been talking about. So I will halt there and look forward to the conversations.
Thank you so much, Angela. I think that was a fantastic presentation, and you brought together so much of what we've already been talking about today. So thank you. And I'm grateful to turn it over to Tracy for the next portion, who's going to focus a little more on the rural perspective too. So it'll be a great perspective to add here. Thanks, Tracy.
Thank you for your kind introduction. Yes, so I'm discussing rural poverty, and this is based on a literature review and community feedback from consultations that happened across rural communities in Ontario. So there you have the link there if you're interested in accessing the report. So these are some of the themes that came out of those consultations in the literature review, and we'll follow it up with the recommendations and action items at the end. So I know it's a bit of a whirlwind, but bear with me. I guess I want to first start with just a scenario. A mother sitting at a home, scared in case her husband gets home early and food is not yet on the table. There isn't a lot in the fridge except a few condiments. The house is drafty and cold, needing major repairs. The kids haven't come home from school yet. She feels depressed and overwhelmed. The internet is spotty and there's no one she feels she can call. This is an all too common story for rural residents today. While in urban centers, we've seen quite a bit of growth over the years. The areas of rural and remote Ontario and the rest of Canada have seen increasing outmigration, population stagnation, or limited growth in many areas. Rural residents accounted for 57% of Ontario's population in 1901, and this has declined all the way to 14% in 2011. These areas are not homogeneous. They reflect diverse community profiles. Some are associated with monolithic whiteness, although rural residents can present multiple identities based on gender, class, race, and so on. Stats Canada defines a rural area as a population of under 1,000 people. We know that poverty is a multidimensional concept linked to multiple determinants and consequences. There's no specific definition of rural poverty relative to urban, although there's an increasing acknowledgement that we can define poverty in a narrow sense or in a broad way. So the narrow looking specifically at a lack of financial resources to meet one's needs, and a broader one that acknowledges both material deprivation as well as the social deprivation that people living in poverty experience. It's also important to note that employment alone does not guarantee a life free from poverty in rural or in urban areas, and that there are many people and individuals and families that are working, often at multiple jobs, trying to make ends meet. Community attachment leads to positive health outcomes and mental health outcomes. It reduces stress, depression, and lowers our risk of mortality. It also improves self-esteem, increases levels of civic engagement, volunteerism, and participation. So those with close social ties have higher rates of self-reported health. COVID-19 obviously is challenging the benefits of these social ties. And we know that social isolation kills. Many poor health outcomes are linked to social isolation and loneliness. So people living in poverty, older adults, like we've heard, those geographically isolated or owing to cultural expectations or language barriers are often the most at risk for isolation. Rural Canadians with low incomes often sacrifice necessities like food and clothing to afford broadband service, and spend a greater share of their income on it than the average Canadian household. Although Bell accelerated its rural internet rollout in response to COVID-19, particularly trying to ensure that, that kids in schools were able to go online during the lockdown, many communities and individuals still do not have access to high-speed internet or have spotty provision. There remains challenges related to the limited nature or fundamental lack of public transportation systems in rural areas. And we know that many people prior to COVID were making exceptionally long daily commutes to and from work. And so that transportation has often been through personal vehicle, so access or ownership of a personal vehicle, with very few or no local buses or infrequent or intermittent schedules of bus networks or transportation networks. Those unable to afford or access transportation face barriers accessing transport or programs and services, and often those with mental health challenges must move to urban corridors to access appropriate services, leaving behind their existing social support networks. So speaking about the access to services, there's a gross underservicing of services in some communities. The social and economic restructuring that happened from 1998 to about 2005 involved the application of urban and market-based models of efficiency that led to many closures or the reduction of services. So this call to streamlined efficiency meant significant regional consolidation, meaning that services were only offered at the regional level. Oftentimes, these were at great distance away from local residents. So we also saw the retrenchment in health and social care sectors, meaning cutbacks in access to basic education, protection services, and less access to civic administrative offices or governmental services.
Hi, Tracy. Sorry, it's Leah stepping in, just asking you to, I know you have a lot of fantastic content. If you could try to get through, it would be appreciated. Thanks.
Absolutely. Just speaking about employment, there's obviously employment has been affected. You know, before COVID, we saw a lot of dwindling of the manufacturing and natural resources, some of those sectors, farming, agricultural, affected before. Those communities that are heavily reliant on tourism, for example, are even more in dire straits as a result of COVID. Formerly, intimate partner violence was believed to be pretty much comparable across urban and rural areas, but now we're starting to see research that indicates that it's higher in rural areas. This could clearly be because there are fewer options for women in rural settings to leave their abusive partners. And as we've already discussed, COVID-19 is compounding the isolation and the barriers that women in these communities are facing. We know that rural households relative to urban ones have lower incomes and can persistently report low income status and higher unemployment. Though the experiences of poverty might be similar across urban and rural areas, the experience of poverty is unique in those rural settings where the services and programs are often lacking. Actually, we have some research that indicates that food insecurity is actually higher in urban areas than in rural settings, although we know that, that food insecurity in the north is particularly dire with an upwards trend over the last few years. The problem of homelessness has largely been overlooked, actually, and underestimated in rural areas. There has been a tendency to focus on home ownership rather than rentals in these areas, and that there are a number of people living in outdoors in tents, RVs, cars, or in buildings that are not really fit for human habitation. Although a lot of people in the hidden homeless population wouldn't actually define themselves as such and are unlikely to access services as a result. I'm going to skip over this slide just because we've already discussed, we've had some of our panelists already discuss some of the issues that Northern and Indigenous communities are experiencing. In terms of health outcomes, access to health, we know, again, we've talked about the social determinants of health as being greater risk factors than those associated with, traditionally defined public health measures, poor diet, tobacco use, low activity levels. Although we know in health, there's shortages across the board, across the continuum of care, shortages of primary care workers and specialists, overstretched care providers, lengthy wait lists, confidentiality concerns sometimes in the community, and the lack of culturally and linguistically appropriate services. Right now, under the context of COVID, the focus is really on expanding virtual services, and of course, these present their own set of challenges. In terms of mental health and addictions, we don't have a lot of literature actually on mental health and addictions in rural areas. We do know that there's a lot of barriers in relation to infrastructure, shelters, mental health access points and crisis services are often lacking. People finding it difficult to access services because of transportation, because of those long wait times that we've discussed. So obviously having access to crisis beds and crisis mobile teams would be helpful, although again, we don't have a lot of literature or research that really has evaluated these in rural settings. This obviously will be necessary, particularly in the context of COVID-19, where we have such a focus on virtual mental health care. So in terms of recommendations that came out of that report, first of all, ensuring that everybody has access to a basic income for all Ontarians across Canada, in terms of especially the working age population, enlarging transportation networks in rural remote settings, encouraging job creation, access to mobile medical and mental health services, building community hubs and networks, and really trying to develop a research network to examine rural trends, because we really don't know that much. So much is focused on the urban setting. Addressing housing and homelessness issues, innovation in education and training, and obviously increasing our efforts to address conditions in Indigenous communities. So I'm just going to leave with you some action items for you to take a look at and for you to consider in the breakout rooms. Reviewing the principles of basic income provided on the BICN website, talking to your local politicians about some of the recommendations that have been made, and really working with our community partners and academics to create a research network to really look at rural trends and poverty specifically. Thank you.